Mechanical alignment, I think, is the best at the moment. Let us first talk about alignment. A lot of people have confusion in their mind about what are these different alignment we are talking about. Now, if you see, this is a paper which have studied normal young volunteers, and they try to find out how many of them have got a normal so-called inverted comma alignment. They found that 11% has both knees normally varus. These are not arthritic patients. These are normal people. To know what is the baseline we are going to begin with. 22% are both valgus. 49%, that is half of them, have got both knees which are naturally little varus. And 18%, that is every fifth knee, is one side varus, one side little valgus. But if you see people when they develop arthritis, about 85 to 90% of the TKR which we do, and all of you know this, are varus arthritic knee. Only about 10 to 15% would be in a valgus deformity. That means there are many people who are maybe to begin with either a straight knee or a valgus knee may end up having a varus deformity when they come to severe arthritic stage and come to you for revision for primary knee replacement surgery. So we do not know which primary alignment would go into a varus deformity which you are going to see when you are actually doing the surgery. So when a patient comes to you like these, it is very difficult to judge how much or what was the primary alignment in this patient. 50% it could be varus, but another 15-20% it could still be straight or a varus. So it is as much as your guess as mine. Now that is why it is not possible to really find out what could be the so-called best alignment for that patient. Unless, of course, the knee is minimally arthritic and patient comes to you in an early stage. Now, let us take what was meant by a mechanical alignment. And the people who developed the knee, like Freeman, Dr. Ranawat, Dr. Insal, they thought that the deformed knee has to be straight, which is a mechanical thing, because we are replacing a biological structure of a bone by a mechanical thing. And when the biological structure is replaced by a mechanical structure, it has to follow some mechanical rules. For example, if you have got a bone under excessive load, the bone becomes strong. On the other hand, a non-biological structure under excessive load will start wearing out. So when you create a knee joint which is made up of non-biological structure like a plastic and a metal, it must be loaded vertically, unlike in a natural way. So what was done is, this is a femoral alignment. So cut was made at 90 degree to that. This is the tibial long axis. Cut was made perpendicular to that. So you create an oblique gap like this with a varus side or concave side little tight. And a surgeon has to release that to make that gap balanced. So there is equal load and equal pressure on both the sides. So automatically the knee becomes straight and your joint line is at 90 degree to the mechanical axis. Very simple to understand, and all of us know all these things. Now, and this is very logical because we are going to put a plastic there instead of a live bone. Now, many times people thought that, okay, why should everybody follow one single straight line knee? Why not go by the nature? But as you understand that nature doesn't have to be varus in all patients, but they thought let us go by a tibial cut which is 3 degree neutral or varus to the vertical axis. So people then started putting the tibial cut at about 3 degree varus. To balance that, the femur was cut little more valgus, maybe 6 to 7 degree valgus. So automatically when you correct it, you get a straight knee, but the joint line here is tilted by about 3 degree, as it happens in a natural knee. And they called it anatomical alignment, not a mechanical, anatomical alignment, right? Simple to understand. Now, there are more brilliant people who thought, well, why should I stop at this? I have to be better than this, right? So then they thought about the so-called kinematic alignment, and they talk about various axes like rotation axis, etc. And these are actually axes which you cannot actually see or visualize or point out. You can make them out only if you know or if you have a 3D structure or CT scan of a knee and a sophisticated software, so that a specific engineer will design it, calculate for you and keep you a patient-specific jig so that you can get accurate structure. And that is why it was a very complex thing, not many people could follow. So they try to create your implant which is fitting ideal to the original so-called implant. And now you understand that from the first slide you realize that just because you have got a varus deformity of a knee, it doesn't necessarily mean that those patients' original alignment would be varus also. It could be very well straight knee or a valgus knee, because even those knee end up having a varus deformity. Is it clear so far? So, the kinematic alignment people wanted to put knee in that mythical so-called normal knee for that patient. So, it would be put in a design whatever they want, and the tibia also was balanced accordingly. So, what happened was you create the joint line which is what they think to be original, and the vertical alignment goes back to the vertical position. So, you have got loading happening medially. Most of these knee look varus, or some of them look valgus. Now, this is about 2-3 degree ideally, and it's very difficult. If you are done knee replacement, all of you know that eyeballing of 2-3 degree is impossible. So, if you try to do it by eyeballing, many of the time you find it is too much varus than what we accept. And people say, don't worry about that. That varus is okay because it is a natural varus. So, you are following the nature. But the problem is, this thing, if you don't do it right, you can go into difficult problem. Now, so you need to have a company which can give you exact 3 mechanical axis of femur and make a patient-specific jig, or you have to use a computer-assisted surgery. And if I analyze myself, out of 8 or 900, maybe 1,000 people, orthopedic surgeon in Bombay, which is supposedly an advanced city, not more than 15 to 20 surgeons have computer-assisted system, and out of that, even handful of them are actually using it. That means we are talking about 99% people who have never used computer system or a patient-specific jig, and we are forcing them to go for this mythical kinematic alignment. Is it right? I don't think that is right. That's absolute rubbish. So, what if the alignment is little more varus or a valgus? We are supposed to get a better outcome. And as I mentioned, this varus valgus with a mechanical plastic is going to cause more wear. It may fail. Now, if you have understood so far, let me make it a little more problematic, because people who were doing it realized that some of my knee are more varus when I try to do this kinematic. So what they did was what is called as restricted kinematic alignment. Meaning what they did, if this is your primary X-ray, you do not know whether that was your primary knee, or that was the primary joint line, or that was on the tibial side, or on the femoral side, whether that was your femoral distal cut or distal joint line, or that was it. So we presume that it is X, and then try to compensate that femoral position by changing your tibial alignment a little more, so that your deformity doesn't become that bad. As you see on the left picture, it becomes less varus. And that means you are restricting the amount of kinematic alignment, and they gave a very fancy name as restricted kinematic alignment. So that's once more added thing, because they felt that we cannot have too much variety. Now all this thing looks good. Are you confused? Well, stop, because it doesn't stop here. Then what we got is, people thought, let us combine the mechanical and then this kinematic alignment, and they had a adjusted mechanical alignment. Meaning instead of mechanical alignment, they wanted to keep a tibia in little amount of anatomic varus, and then adjust the femur as required, but to get your varus alignment to about 2 to 3 degree to match the so-called original one. So now you have got what? There is a so-called gold standard mechanical alignment, but if you keep it out, because you don't want everybody to be straight, we have got kinematic alignment, a restricted kinematic alignment, an adjusted mechanical alignment, and anatomical alignment. And if you realize, why are we doing all this rubbish? All because all these people who are developing newer and newer technique want to solve that problem of unhappy patients and want to make them happy. But if you analyze further for next 2 minutes, what are the reasons actually for poor outcome in TKR? And all of you know that if you are doing TKR in a reasonably big way, The people are unhappy because of many reasons. It could be malaligned tibia, which is undercorrection or overcorrection of your deformity. It could be undersizing or oversizing of your femur. It could be unbalanced, under-release or over-release of your knee. It could be mal-positioned implant like under-rotation or over-rotation of femur, the tibial slope, the reduced posterior offset. It also could be patellar issue, mal-tracking patella, too much overstuffing of a patella. It could be poor soft tissue handling, excessive arthrofibrosis, RSD, stiffness, low-grade infection, loosening, poor cementing, poor bone quality. I mean, you have got at least 20 different causes where a TKR may not get the best outcome and patient may be unhappy. And if you tell me that just changing a bit of 2-3 degree of alignment and putting your femur in little 2-3 degree here and there, you are going to solve all these people a happy life, I think I'll take it with not a pinch, but a loads of salt, because it's just not acceptable. Let's take the literature, what they saw. And this is an excellent paper. The paper is labeled as looks good but feels bad. So these guys took more than 1,000 TKR cases from their hospital and found out 71 unhappy patients where there was no malalignment, soft tissue balance was good, radiological picture was good, no infection. And they compared that with 148 other patients who were apparently happy and matched for range of movement and everything else. And the factors they found in the people where people were unhappy was obesity, female gender, diabetes, pulmonary embolism, pulmonary problem, previous surgery, disability compensation, and over-expectation. And none of that you can actually change by your alignment thing, right? So you have some questions and a different answer for that being propagated. Now let us see whether they come, how do they match. Now, basically, people with mechanical alignment, this is a 40-year established technique. It's a long-term good outcome. It is simple to do. You don't require PSI or CT or COS, and all surgeon can do it. How does it compare one to other? Now, we do not want to give individual report. These are the most recent analysis. The systemic review, we compared mechanical and anatomical one, and they found that in this review, systematic review, only design surgeon has shown 10 real good follow-up. And my previous speaker has mentioned about that. But these reports are not corroborated by good quality independent randomized control trials. That's the outcome.
Sir, requesting to wrap up.
Last two questions. Another systematic review, no difference between outcome of KA and MA in 5 out of 6 people. So question is, do we then need kinematic system or kinematic alignment? Be sensible, we don't need that. Do what is time tested. Do not make the simple TKR surgery an unnecessary complex operation. Thank you very much.